Our next presenter, Courtney Tresslar, a retrospective review of Bromelain-based enzymatic debridement, a single center's experience from here at MUSC in Charleston.
Hello, my name is Courtney Tresslar. I am one of the third-year medical students at the Medical University of South Carolina, representing the South Carolina Burn Center. As you heard, today I'll be presenting our institution's experience with bromelain-based enzymatic debridement. Okay, so listed here are my co-authors and any disclosures. None are relevant to the talk today. So as many of you probably already know, since the 1960s, tangential excision has been the mainstay of burn debridement. This technique is associated with decreased mortality, infection, and length of stay. However, it's non-selective by its nature. And so an alternative to traditional tangential excision, bromelain-based enzymatic debridement, received FDA approval in December 2022. This technique is less invasive. It reduces the time to complete eschar and wound closure, as well as reducing autograft utilization. And so the use of bromelain-based enzymatic debridement is widespread across Europe, and many guidelines have been published for its use, as you can see here. However, the use of this technique is still relatively new in the United States, and so description of its use in a clinical setting, is limited, which is the purpose of this talk today. And so our study was a retrospective single institution chart review of adult patients with burns who underwent bromelain-based enzymatic debridement between June 2020 and March 2025. This study included patients that were treated under the NEXT trial as well as commercial use patients. This study was primarily designed to describe our process at our institution, but regarding data, our primary endpoint was mean length of stay per percent TBSA. We compared our value to that reported by the Burn Care Quality Platform Registry. Secondary endpoints, we looked at pain management strategies, time interval between bromelain debridement and additional procedures, and the types of surgical procedures used for wound closure. So a little details on dosing. We used 2 grams of the enzyme for each 1% TBSA. Per the FDA approval, bromelain may be applied for up to 15% PSA in one application. A second application may be applied 24 hours later, but the total treatment area between these 2 treatments must not exceed 20% PSA. So now, kind of the meat of this talk, I'm going to walk you through the protocol at our institution. So as a note, the night before, we avoid the use of silver or iodine-containing products. This is because it has the potential to inactivate the enzyme. The day of, the old dressings are removed and the wounds are thoroughly cleaned. Next, the wounds are soaked in sodium hypochlorite for 2 hours in order to decontaminate them and prevent any bacteremia. After this 2-hour soak, the wounds are washed with soap and water. And now we're moving on to the actual bromelain application. So first, a thick petroleum jelly border is made, as you can see in this first photo. Then the bromelain is applied between this border, and we wrap this in a transplant dressing. The edges are taped down in order to prevent leaking. And then we wrap a layer of gauze on top. During the procedure, patients are placed on 2 liters nasal cannula and the vitals are checked to Q5. These include heart rate, blood pressure, and O2 saturation. The patients are monitored to ensure their pain is adequately controlled and the dressings remain in place. Oftentimes, the next debrid will slog off, and so it may require redressing several times during the procedure. After this 4-hour treatment interval, the enzyme is removed using a blunt object, usually a tongue depressor, in order to scrape off the dissolved eschar. And you can see our final photo is post-bromelain treatment. After this, the wounds are once again washed with soap and water and then soaked in saline for an additional 2 hours. And so it's a pretty lengthy process. The saline-soaked dressing is then removed and the wounds are redressed with antibiotic ointment and a petroleum-impregnated gauze. So many of our patients, as I'll talk about later, go to the OR the same day. But if they are not going to the OR that same day, one of our goals is to keep the wounds as moist as possible. And so we place them in a thick layer of surfactant gel or antibiotic ointment. Final notes is we want to avoid the use of silver and hypochloric acid after the treatment as well. The acid because it has the potential to dry out the wounds, and then the silver because it has the potential to desiccate the wound and create a pseudo eschar. A final note, patients are pre-medicated 30 minutes before the procedure. Okay, so here's an example of a 4% deep partial thickness flame wound that was treated with bromelain at our institution. The far left photo shows the wound pre-debridement. The photo in the middle shows it immediately after, and then our final photo is at a 3-month follow-up. This wound was also treated with skin cell suspension autograft and polylactic acid sheet. So looking at our study demographics, we had 53 total patients. Our mean age was 42 with a range of 17 to 76. The 2 17-year-olds were included because they were treated at the adult hospital. The majority of our patients were male at 77%. Our mean TBSA was 17%, and our mean percent full thickness was 6. So looking at pain management, most of our patients were pre-medicated with ketamine. A majority, about 60%, received this orally, while about over a quarter received it via IV. 3.5% of our patients had a nerve block, and the remaining 10% received some form of alternative primary pain medication, such as oxycodone, fentanyl, hydromorphone, etc. So now we wanted to look at the types of procedures used in addition to bromelain debridement. And so you can see that a variety of procedures were used. A majority of patients, 66%, had skin cell suspension autografting after debridement. 62% received a split thickness skin graft, and over half received a polylactic acid sheet. 30% received allograft. And then a small percentage of our patients received a xenograft skin substitute. So as you can see, bromelain debridement does not limit the types of surgical procedures that can be utilized in combination. We also wanted to look at timing these additional procedures post-debridement, and so 28% of our patients went to the OR the same day as debridement, and over half went the next day. 17% went 2 or more days post-procedure, and then 4% did not have any additional procedures. These were patients who unfortunately passed away from their injuries. So I'll finish with some final data. Our average length of stay per percent TBSA was 2.1 days. This is less than expected based on national data from the BCQP registry. 4 of our patients did pass away from their burn injuries, as mentioned earlier. Our average number of grafting procedures was 2, and the average number of laser procedures was 1.1. And so in conclusion, we can see that patients treated with bromelain-based enzymatic debridement had a shorter length of stay than expected based on the BCQP data, but this difference was not significant at 2.1 versus 3.3 days. We also found that oral ketamine can be effectively used for procedural anesthesia in patients undergoing this form of debridement. We found that a quarter of our patients underwent an additional procedure the same day, and so there's no limitations in that regard. And in a similar vein, we found that a variety of surgical procedures can be utilized in combination with this form of debridement, and so we don't have to worry about any limitations in that regard as well. As far as future directions, we just need to continue to study and refine best practices for this new form of debridement in order to optimize the real-world use of bromelain for burn patients, as well as provide the best care for our patients.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.